Hello, ladies and gentlemen. Today you will see about real-time ultrasound guided thoracic epidural drip infusion method in prone position PX view, a novel approach by Professor T. Sivashanmugam, who's a professor in Mahatma Gandhi Medical College, Puducherry, where I studied my PG there under him and Dr. Ravi Shankar. This is how you normally do the thoracic epidurals in that view, but how we do it in real time is the needle entry is in this manner. It goes, what you need to know is the spinous process of each vertebra, and then the needle lands on the lamina of lower vertebra, and further the needle lands on the transverse process of further lower vertebra. This is a zone anatomy you need to know. This is how the needle goes from lateral to medial. It hits the upper summit of the lower vertebra and enters into the T4, T5, T4 or T5 space. And this is how you need to keep the probe in a transverse sagittal oblique view, the cross view. What they say is a cross view. So the sono anatomy, this is how the needle entry, as I shown previously itself, it hits the upper summit of the concerned vertebra and enters into the epidural space. I have done at T5, T6 level with the patient in prone position. What you have to do is, first you need paramedian sagittal view showing the ribs of the thoracic, and then further you move in, you see the paramedian sagittal costotransverse view, and further if you move in, you will see the transverse process of the thoracic vertebra, and further as you move medially you will see the lamina. At this level you need to rotate to get the cross view, that is a cross PX view. So what the sono anatomy you will get is, this is a cross view, the PX view. The sono anatomy, this is how it looks. That my probe is, the marker is in the lateral. Manoj Karmakar keeps it the probe marker medially. This is how the sono anatomy looks like. What you will see is the spinous process of T5 vertebra and the lamina of T6 and the transverse process of T7 below, if you are performing a epidural at T5 or T6 level. This is how it looks, and the needle entry point comes from lateral to medial. That's how I shown in that, depicted by an arrow. So when you keep this is how we need to learn and to get the sono anatomy. Let's see how it goes in real time. I'm using a 19 gauge echogenic epidural needle, so that you will see the whole length of the needle and the needle tip. First you should get the cross PX view at the desired level if you are going like T5, T6, and when you go and hit the ligament of flavum, you attach the drip infusion, and then further if you advance, you will see the dent of the posterior dural column complex. Sometimes in thin individuals, usually you don't see it, and now in this patient is very thin, you can see the anterior dural complex also, and when the drip infusion falls off, the posterior dural complex is pushed further anterior. This is not normally seen in every patient, very difficult, but in thin patients sometimes you can appreciate it. So when you get into the epidural space, you get the drip goes in. This is how it in real time ultrasound guided looks like. You can see the anterior dural complex in thin patients, not in all patients. Now as the needle approaches with the introducer to the summit of the summit of the concerned lamina, and then you attach the drip infusion method, and then further if you go in, you will enter into the epidural space, and you will see the posterior dural complex will dent. Now you can see the dent of the posterior dural complex because of the drip that goes into the epidural space. Now you can see the dent of the posterior dural complex. And then with the successful placement, you can give a single shot of 10 ml for any segmental thoracic epidural, and you can have a good, and you can make the patient walk. I made this patient walk after doing an open appendicectomy. Thank you guys. Keep exploring. Welcome.